Good evening, everybody, and it's indeed an honor to be here amongst you, and I'd like to thank the Association for this invite on behalf of Apollo Hospitals. So I'm here to speak about preventive health, occupation and health, and use of data analytics. So let me touch on preventive health and occupation health to start with. There's nothing that you don't know, but we'll just touch on it before we progress. So preventive health is a branch of medicine. It's the backbone of healthcare, and it helps to promote, preserve, and restore health, and it minimizes suffering and distress. So what are the objectives of preventive health? Certainly, detection is an objective of preventive health. Detection of non-communicable diseases. So if you look at the top list of non-communicable diseases, you will see that coronary artery disease tops the list, followed by cancer, chronic respiratory diseases, and diabetes. So the statistics say that 74% of the deaths across the world is due to chronic diseases or non-communicable diseases, out of which 86% of these diseases are seen in growing countries like India, low income and medium income, and 86% of diseases due to NCDs are from these countries, which make about 77% of deaths due to NCDs in countries like ours. So what contributes to non-communicable diseases? Lifestyle, definitely. Unhealthy diet, lack of physical activity, alcohol, and tobacco. So these issues need to be addressed as important objectives of preventive health. Also, healthy mind. Healthy mind is very important. We need to address stress, depression, and anxiety, and the body and mind work together, and they are one, so a healthy mind makes a healthy body. Detection of communicable diseases can also happen with preventive care. For example, you can detect hepatitis B, hepatitis C, amoebiasis, and so on and so forth with just routine health checks and tests. Occupation medicine is the subspecialty of preventive medicine. It is concerned with the health, safety, and performance of workers, and it promotes and maintains highest degree of physical, mental, and social well-being of workers in all occupations. So what are the objectives of occupation health? All of you would know that very well. Promotion of workers' health, maintenance of their health, creating a safe working environment, and maintaining their health and the safe working environment to increase their productivity. So just for ease, I've classified prevention into primary, secondary, and tertiary. Thinking about primary prevention, health promotion. Health promotion is very important amongst our employees. Creating health awareness through posters, videos, health seminars in our corporates would definitely help them. Vaccination comes next, primary prevention through vaccinations. So for example, food handlers should have their typhoid vaccines and hepatitis A vaccines. Anybody with NCDs, irrespective of their age groups, should have an influenza vaccine. Above a certain age group should be vaccinated against pneumococcal pneumonia. These are a few examples of primary prevention. Safety at work. Definitely safety at work is a form of primary prevention. And it's not enough if we look at safety at work. We have to supervise to make sure that the environment is safe always. Secondary prevention. Secondary prevention is pre-placement examinations, preventive health checks, and periodic monitoring of the outcomes of the preventive health checks, education and counseling of the disease that have been diagnosed, and effective healthcare services, which could include treatment of acute illnesses or acute on chronic illnesses. Tertiary prevention. This is something that many of us don't think about. Chronic disease management. You know, we send our employees for a health check. They come back with uncontrolled diabetes. What is our plan? What is our plan for those with chronic kidney disease? So we need to think of robust plans, and tertiary prevention focuses at reducing disease-related complications. Education and counseling is very important for tertiary prevention. Now, how many of you have had a health check in the last 1 year? Please put up your hands. Wonderful. How many of you have serviced your bike or car? Everybody, I think. You should have, yes. So when you had your health check, did any of you feel that you could have had an extra test that you really needed, like a treadmill or a mammogram? Anybody? Or were you just happy with the set of tests that you were offered? Okay. So what does the employee need, and what does the employer offer? Does it match? Okay? Does one size fit all? No, it doesn't. So what do we do? How do we work around this problem? So we bucket our employees into different buckets. So we bucket them into age, gender, symptoms, medical history, family history, personal history, and occupation. Let me take you through a simple example. 40-year-old obese secretary known to have hyperuricemia reported for an annual health check with a history of back pain and a family history of diabetes, gout, and breast cancer. So we all have basic tests that our organizations offer. And the basic tests, I believe, should be comprehensive as it can be to pick up diseases. So the minimum that I would recommend is a hemogram, a fasting sugar, HbA1c, definitely a postprandial sugar if they're diabetic, their fasting lipids, liver function tests, urea creatinine, a thyroid test, ultrasound of the abdomen, and urine analysis. This I would consider as basic. Now, looking at the buckets in which we will put this particular person, age. So she's 40, she definitely needs a mammogram. Screening starts at 40 for breast cancer. So talking about mammograms, if there is a strong family history of breast cancer, we must start screening at the age of 35. Gender, pap smear, definitely. So pap smears are done every 3 years in most countries. And if you have the same provider who does pap smear, you can stick to the same provider. In countries like this, applies only to those who have normal pap smears, so the interval should be 3 years. In countries like America, where they do pap smear along with a HPV testing, it can be done once every 5 years. So based on her symptoms, yes, she's a secretary, she's probably sat all day, she's obese. So musculoskeletal assessment is an important part of her assessment. And the medical history, she has high uric acid levels, so she has hyperuricemia, so you would check her uric acid levels. Family history, definitely mammogram, considering her family history. And personal history. I don't know of a single secretary who's stress-free. So definitely stress assessment is very, very important. Using the GAD would also assess for depression. Occupation, she's obese, she's probably sat all day or stood near her boss, she's probably using the computer, she's probably hit 40, the age in which one wears reading glasses, and anybody with stress suffers with sleep as well. So a sleep assessment is something that I would do. I would probably go a step further with this lady. Since if she's obese and she's snoring and she has sleep issues, I probably would do a sleep apnea score. I would use like a stop bank questionnaire and assess if she has sleep apnea. So moving on to the next case, a 55-year-old driver with diabetes reports for a health check. He's a heavy smoker and he consumes 30 units of alcohol a week. He complains of mouth ulcers, numbness of the feet, and he gave a family history of diabetes, coronary artery disease, and colonic cancer. So he's got quite a lot, this gentleman. So we think of the basic tests, and above that, we look at the buckets. Age, definitely 50, we need to start prostate cancer screening, so we do a PSA. Gender, of course, PSA stands good. Anybody above 40 would need an eye test. Symptoms, so he has 2 risk factors. 1, he drinks a lot. 2, he's diabetic. He could have developed diabetic neuropathy, so we'd suggest a vitamin B12 and a biothesiometry. Depending on his medical history, yes, he's diabetic. He's probably developed neuropathy. There could be some end organ damage, so I would definitely look for a urine albumin creatinine ratio and an eye test focusing on retinopathy. Family history, there is a family history of colonic cancer. Screening definitely should start after the age of 50 and would recommend 3 yearly screening intervals. And his personal history says he's a smoker and he's diabetic. That puts him under very high risk of heart attacks, so PFT and TMT is something that I would recommend for him. Occupation, yes, he's a driver. Traffic isn't great. I was stuck in traffic and I know how stressful it was, so he must be going through a lot of stress. So I would assess for musculoskeletal, I would assess his musculoskeletal system, I would assess his stress levels and check him for depression and sleep issues. So if you look at it, you have a basic package and then you add as to what is needed for your employer. So one size doesn't fit all. And if we are just doing a bunch of tests for everybody, then are we justifying what we're doing for our employers is a question. So we've done health checks, we've done a good job with our employees. Where do we go next? What do we do? How do we monitor them? If we haven't got data, we don't know where to take it from there. So it becomes a one sort of touch point every year and we don't know what to do with it. It's like standing blind and deaf in the middle of a highway. I'm just going to show you a sample data of health of the nation in which we've looked at manufacturing, industry, construction, oil and gas, and automotive. So we looked at 14,648 individuals, out of which 58% had NCDs and 44 of them were in the age group of 46 and 60. That raises the question, what happened to the other 56? The other 56 are distributed between less than 30, over 30, and predominantly between the ages of 30 and 45. So what does this say to us? About 30 years ago, diabetes was the disease of 70-year-olds. Then it became the disease of 60-year-olds and then 50-year-olds. And now we see more and more people diagnose more and more people with diabetes in their 30s. So we also saw that dyslipidemia was the most in all of these, followed by hypertension, then diabetes, and obesity. Stuck?
Somehow it has failed.
I don't know.
Slide is correct.
Is it? Okay. So I think I'm not going to be able to show this slide, but I'm going to talk about it. So generally, data analytics is extremely helpful. As you see, the data that I can't showcase now shows diabetes as well and hypertension. And we look at comorbidities and obesity as well. So people obese have more than 3 comorbidities. About 70% of them had more than 3 comorbidities. And we often, when we talk about obesity, we talk about cardiac disease, we talk about diabetes, we talk about hypertension. We fail to address cancers. Cancers are, obesity is one of the topmost reasons for cancers. We don't address that with our employers. And obesity also causes a lot of musculoskeletal issues for our employees and therefore a lot of absence from work. So as far as data analysis is concerned, what do we do with the data? So we have the data, what do we do with it? How do we process it? So when we process the data, first thing is predictive. What we have here is what we predict from this. It's just analysis. We say so many people have diabetes, so many people have hypertension, and this is what we've seen. What do we do with this? We take this data, process it. Unfortunately, I don't have the slide, but I'll talk through it. We process the data, and when we process the data, we understand trends. So the trends here, if I had showcased the dyslipidemia slide, you would have seen that 40% of the entire population had over 40 and 60 had dyslipidemia, which leaves 60% within the age of 30 and above 60, which actually says that there are more people dyslipidemic in their 30s and 40s than in their 40s and 60s, which is very unfortunate. So when we do the predictive analysis, what we do is we take particular populations in our organizations, those employees, bucket them and treat them. So if you look at diabetes as well, many of these diseases are starting from 30 onwards. So it's about picking our healthy employees who have obesity, maybe one comorbidity, working on them so that they do not progress into tertiary care. So what we offer now is secondary care. Tertiary care is chronic disease management. So we prevent them from moving into tertiary care. Again, unfortunately, I can't show you this slide. Apollo has worked on artificial risk scores derived by artificial intelligence. So our AI-CVD scores are now being used worldwide. And in my presentation, I had about 26% of this entire population who actually was at a risk of heart disease. And most of them were between the ages of 45 to 60, and the other majority between the ages of 30 to 45. We also have risk scores for COPD, or chronic obstructive airway disease exacerbations. So what we do is we take the patient's medical history, we calculate the air index quality of that particular city, and it tells us about how severe the exacerbation will be, which is a very useful tool in industry. We also have risk scores for liver fibrosis that we've worked on, and we're working on risk scores for progression of kidney disease to kidney failure. So these are very useful tools that one can use to determine the progression of disease in their organizations. So the other thing is, how are we going to manage? We have this data, we know who is at risk. How are we going to manage it? So as for primary prevention, continuous engagement with our employees, bucketing them into necessary buckets. How many of you here have electronic medical records in your organizations? It's a very few. So the rest of you, if you were to have a healthcare provider from outside, you may want to collect the data from them in a form like a corporate health report, which makes you understand the entire health of your corporate, or in a format in which you can bucket your patients depending on their severity, depending on their conditions, so that you can look at a care continuum. So that a health check is not a one point of contact for an employee, and walking into your clinics for acute treatment, again, is not a one-point contact. What we really need to do is to offer a care continuum. How are we going to offer it? Say, I'll give you an example. Somebody over with a HbA1c over 12, that person will need frequent monitoring. It's just not a health check and then coming to you in your clinic for a complication that has occurred because of the diabetes. So how do we manage the patients? Medication management is important. Frequency of blood tests is important. So we look at these sort of things. Lifestyle is extremely important. You can sort of think of, putting up a gym in your organization, engaging a physiotherapist, engaging a gym trainer, engaging a psychotherapist. So psychology is really, really important. Mental health is very important, and that's something that you need to work on. I don't think I'm going to be able to show any more of my slides, but that's okay. So I will move on to take questions, if any. No, it's corrupted. Yeah. Yes, so there, I think I've gone through some of these slides. So that is our AI-CVD risk score. So when looking at the patients that we studied, we realized that 10% were at high risk and 26% were at moderate risk. That's 36% at a risk of heart disease. So how do we use data to help organizations? We use data to help organizations improve the quality of healthcare, lower organizational health cost, and to enhance employee satisfaction. So improving quality, as I mentioned, electronic health records, very, very important. Descriptive analysis is what I showed you earlier, that just describes the state of your corporate as far as diseases are concerned. And predictive analysis extracts the data and uses it to predict future and behavioral patterns, like AI-powered engines for cardiovascular disease and others. Prescriptive analysis is what I really need to talk about now. It mitigates future risks and helps make better decisions and well-defined protocols. So how many of you have protocols for chronic disease management, and how many of you follow a care continuum? Nobody. So that's a learning today that needs to be worked on, and it can be done electronically so that your employees can key in their values. So somebody who's has a very severe hypertension and is not looking after himself, or somebody whose diabetes is out of control, your nurse or your occupational health department can key in those factors for your doctor to see in the form of an app. So there are a lot of options there. And robust care continuum helps to reduce absence at work. So our employees are our most valuable assets, and we must look after them. I think the best thing that one can have is a gift of health. So I think we must give our employees the gift of health.